Good morning, everybody, and welcome to the East Midlands Ambulance Service Annual General Meeting. I'm going to first of all welcome and introduce our Chairman, Karen Tomlinson, if I may, please. Karen.
Thanks, Richard. I'm your new chairman. I started on the 1st of August, and this is my first annual general meeting, obviously in that capacity. So I welcome everybody for coming today. I'm looking forward to hear how the last year's gone, although I have been here, but in a slightly different role. So back to you, Richard. Okay, for the story.
Thank you very much, Karen. If I could have the first slide, please, Anthony.
Is it not appearing?
Yeah. Next. Okay, so thank you very much. As I have just described, it's the annual general meeting this morning. A very brief agenda which we have, which will be an overview for myself, and then I'll have an opportunity to introduce some of my executive team who will be describing some of the challenges and achievements we've had through the past year. So next slide, please. So thank you very much. As described, we have a new chairman, so Karen, who's just introduced herself, and we're all immensely proud to welcome Karen to the organisation, but also taking an opportunity to thank the work and dedication from our former chairman, Pauline Tagg, who has since left the organisation, moved on to pastures new and not unfamiliar territory, where she'll be working in the LLR ICB as a non-executive director. So we'll still have some contact with East Midlands Ambulance Service. So a huge thank you to Karen, to Pauline, who was actually supported by Karen as the vice chair through the past year. I also want to start with a huge thank you. As you will all know, it's been a hugely challenging past 12 months, both in general society, but also in the wider NHS, where exactly the same as the broader NHS, the pressures which the ambulance service experienced were huge and significant. And this morning, Ben Holdaway, the Ops Director, will be describing some of those operational challenges that we have faced. But without the dedication and determination of our workforce, we would have not have achieved what we have done. And without a shadow of a doubt, day in, day out, the efforts and the determination which our colleagues demonstrate has been absolutely exceptional. And it's certainly a huge testament to each and every one of them for everything which has been achieved. So personally, on behalf of the wider board, I want to say a huge thank you for their achievements. There's no surprise with the amount of pressure and the relentless nature of the workload of the ambulance service. We've had to do an awful lot more to be able to make sure that our frontline staff are truly supported. And that's our staff, our volunteers and our wider colleagues. And we've put a lot of additional actions and support in place to focus on staff welfare and well-being. And that, I believe, has been very effective. But what I will say is we can never do too much in that domain, and we will continue to focus immensely on staff support, staff well-being. Other actions which we experienced last year, so we welcomed a significant number of VIP visits, and a couple of which I would describe. We had Her Royal Highness Princess Anne came to open the South Park Joint Emergency Services building, South Park in Lincoln, which was absolutely a fantastic occasion and something we were all really, really proud to be a part of. We also welcomed Amanda Pritchard, the Chief Executive at NHS England, to Leicestershire, who met a number of operational ambulance staff, and she was very, very impressed by what she observed and what she experienced. We also, as we are all here today in our newly refurbished Emergency Operations Centre and Trust headquarters. So when the pandemic commenced, all of our corporate staff were in effect decanted from the building and went to work home working or working in alternative locations. And that brought about a huge amount of challenges, because what we had to do was create an operating environment where our Emergency Operations Centre staff, so the 999 call takers, the dispatchers and others, had to be appropriately socially distanced, because of course the risk to staff within the building, had there been an outbreak, of which we did experience quite a number, it could have had a huge profound impact on our ability to respond to patients in the community, because of course the beating heart of the organisation is the Emergency Operations Centre. So if we are unable to take the 999 call in the first instance, the rest would not be able to follow. And I'm absolutely delighted that a year, 18 months on, we're now in a place where the refurbishment of this building is now completed and finished, and we have a really, truly fit for purpose operating environment. What we also have to do is to make sure that we continue to focus on our other estates, so our ambulance stations, our other control room over in Lincoln, which again is an area which is key to our organisational delivery. But also it's really important for our corporate staff who will now slowly be returning back into the working environment, so where we have a truly functioning operating headquarters. And that's something I'm really, really pleased to have seen. What we've also continued to do is focused on our big three areas. So that's where we talk about respond, develop and collaborate. And what I'm going to do now is going to hand over to Ben Holdaway, who's the Director of Operations, who's going to talk us through some of the operational challenges and operational deliveries over the past 12 months. So, Ben.
Thank you. Morning, everyone. As we
Just stand a bit closer to the screen.
Okay, of course I can. Morning. Just to start, I'd like to follow on from Richard said about a huge thanks. It has been a really, really challenging year for service delivery, and our staff, volunteers, our leadership structures have done an amazing job to see us through that last year. So just wanted to reiterate what Richard was saying, the great work we've had from everyone. So first of all, calls. So as you can see on the slide, we've taken 1.2 million calls over the last year. That's a call about every 25 seconds, and an increase on the previous year, about 200,000 calls. I think what this hides, though, is what we've seen in the year is some spikes that we've never seen before. So we used to always plan for New Year's Eve, where in the early hours of the morning we'd be taking a call every 3 to 4 seconds. We've had days in the middle of July where we've been doing exactly the same. There's no rhyme or reason for that. We're just seeing days now that are busier than we've ever seen over the winter period. Heat wave was a good example. You know, we saw a huge spike in activity in the first one, but that didn't follow through to the second one, where we didn't see the same sort of activity come through. Because of the increase in calls, we've been looking to have some big investment in our call centres. Richard talked to how we've done a lot of work around the environment they work in, but also we've recruited will have recruited 70 more call takers to help with the demand. And that will take our establishment now up to 210 call takers, which is a huge amount compared to where we were. Okay, do you want to move forward a slide? Oh, no, sorry. Before I do it, just talk about the other. So we take a call and the call becomes an incident then that we deal with. And we've also seen an increase in those incidents. And then an incident can result in a response, so we send a vehicle. And the reason I say can is because sometimes we'll deal with that incident in a different way. We'll either, a clinician will call them back and see if there's an alternative, a more suitable route for that patient, or we may advise patients to make their own way to a location. So what we've seen over the last year again is our calls go up, our incidents go up, but not necessarily our responses, and that's because we're dealing with those patients in a more appropriate way for them. Move forward. So delays at hospital and demand have been a huge challenge to us last year. So just to set some context on hospital delays, the target for us to be able to hand over a patient is 15 minutes. So we should arrive at hospital and hand over a patient within 15 minutes. Doesn't say it on the slide, but year to date, our average for that is 40 minutes. So you can just see how far away we are from the national target being able to hand our patients. And with 40 minutes being an average, that means we have some hospitals that are well above that, over an hour in some places. But as you can see on the slide, last year we lost 125,000 hours to hospital handovers. That's an increase of 110% on the previous year where we lost 59,000, or just short of 60,000 hours. And just to put some context to that, if you put that into what that means to us on the road, it's 10,500 12-hour shifts, or an average 29 shifts a day, where an ambulance is just stuck at a hospital, not responding to patients. And on average, on a 12-hour shift, we'd respond to 4 or 5 jobs. So you can see if those 29 shifts were available to respond to patients, we'd be going to a lot more patients, and that would then mean patients won't be waiting as long as they are doing for a response. So it has a huge impact on what we can do and how we can do it. And another way we look at this is each month, recently we've been losing around 15,000, 16,000 hours. We put out in Northamptonshire about 16,000 DC ambulance hours a month. So in essence, what we're doing is we're closing one of our divisions and they're not working, and we're having to pick all that work up by our other divisions. So that's the impact this has on our ability to respond to patients. And that's why Leon, Nicola and myself are working so hard with the systems to try and see that improvement, because we recognise that this is a system issue, not an ambulance issue or necessarily an acute trust issue. It's more of a system problem that we're very keen to be involved in and working with the partners to fix that. Move forward. So this, I won't go through this. This just outlines our performance, and as we said, we've had a really, really challenging year. Our category 1 mean is 8 minutes 53 seconds. The target is 7 minutes. So we're out of target. And for the 90th percentile, it's a 15-minute target, and as you can see, 16 minutes and 1 second is where we're at. I won't go through all the standards, but it stands out there. We are not meeting the standards for all the reasons we've alluded to in the previous slides. Just drop back one, because there is something I do want to pick out on that slide, and that's the HCP admission protocols. So you can see there, actually, we're not far off the hour mark, and the 2, 3, 4 hours, we are actually meeting those. And those are jobs where a HCP has already been out to the patient and says they don't need any clinical intervention, they just need to take them to hospital. And what we did a couple of years ago was we put a specific transport layer in to deal with these calls. And you can see the impact that's having. So although we're not getting to the emergencies as quickly as we would like, we are being able to respond to those HCP calls through that dedicated tier of workforce we've got. So it's a good example of where we recognised an issue, we did something about it, put something specific in, and it has paid off in terms of how we're responding to those. Okay, so I talked about how we're having to change our way that we respond. So a few things that we've done. I mean, this is 4 bullet points. There's lots of things we've done over the last year, but we've picked these out as the key ones. So we have a team of doctors now working in our control room to support our clinicians. So we have a multidisciplinary team in our control room that's now got the doctors in there as well. And they're made up of GPs and ambulance doctors who are used to working in the ambulance sector. And they really support 2 ways. They can talk to crews on scene and give advice on what the most appropriate course of action for that patient. And that's not just the low acuity work, that's the trauma work that we do as well. So a real good impact for crews on scene. But also they talk to patients, they do video conferencing to enable us to make sure that we're doing the best for that patient. Been a really good success story. And now he's well embedded into our operations, well received in the control rooms, and equally well received on the road. I touched on this earlier on. So this year we trained 50 new call handlers. We've actually had to recruit to get that net of 50. We've actually recruited 120 call takers. That's how hard it is in terms of the labour market now and people moving on out of the control room. So we've recruited 50. Our plan by Christmas will be to have 70. All the recruitment and training plans are in place, so we'll have 70 additional call takers in situ by winter. And we've also welcomed an increase in newly qualified paramedics, and across all parts of our organisation, all the divisions have seen an increase in paramedics joining as well. And I've talked about technology a little bit, but it's a really important part of our business now. And what we did over the last year is we issued all our frontline clinicians and staff with an iPad, which gives them the ability to interact better with the system, look at records that again can help them make the right decision for the patient that they're attending. So again, with lots of more we plan to do with the iPads, but it's a really positive step forward for us. Okay, last I just want to touch on community first responders. So a really important part of our service delivery is our volunteers. Really great support. They were fantastic through COVID. They work wonders for us, and it's a really important part of our organisation and what we do. And as you can see, Mick Barnett-Connolly, who leads this team, has developed a new strategy which runs from 2022 to 26. And just a couple of things I'm going to touch on that it includes in there. So you can see the Service 1, an enhanced first response model, and in essence this will give some CFRs additional skills to be able to support us better out there in the field. So those enhanced skills will enable us to send them to more jobs than we currently do. And alongside that, there's a falls response. Falls has traditionally, for many, many years, been one of the areas of demand that continue to go up. And there's been a problem to us in terms of being able to respond to those quickly. And unfortunately, people on the floor wait far too long for a response from an emergency response. So we've seen that, and we've worked with the community teams to try and put a volunteer process in place where they can go and give that first aid, help them off the floor if that's all they need and they don't need an emergency response, but give that initial eyes on to enable us to make better decisions what's happening. We hope that will grow. We hope that will be a success, but it's one of those schemes where we're watching it to see how we can develop that further. Second one is we recruit to a community resilience volunteer trainer role, and that role is really supporting with our resuscitation strategy. You've seen now how important bystander CPR is. It's really important if someone needs CPR, that the hands-on is as quickly as possible. So we see this role as really helping us develop that in the communities and to train as many people as we can. So should that unfortunate event happen and they're there, they can get hands-on as quickly as they possibly can. So we've got 30 dedicated volunteers initially, role-specific training, and they're also level 1 in basic life-saving skills. And their also role includes community public access defibrillators, so DFibs, management and the education of those within schools. So the importance of the use of DFibs, but also the hands-on as well. So we're doing the education to as many school children as we can. And that role will be really key in able to progress that as we move forward. And the last service to touch on is another new role we've put in place, which is a volunteer operations support worker role. And this role is really to help us support our operational staff. So I talked about how the volunteers were a vital part of our response to COVID, and we really recognised that during that period. So in the strategy, we recognised that, and we've put this role in place. And it's multifaceted again, but in essence, what it's doing, they can move vehicles, so we're not wasting time through our core staff having to move vehicles around. They can help us with logistics. They were a massive part in our vaccination programme, enabling us to get the drugs to the right places. So they can do all sorts of things to help us keep the wheels on the road and help us to respond to patients quicker than we're currently doing. And again, initially we've got 15 just to see how it works out, but we hope that we will be expanding that in the future. And Richard talked earlier on about welfare of our staff. We're coming into the winter period again, and we don't know what's coming with winter, but everything tells us it's going to be really difficult again. So one of the key elements we've got within our winter plan is the welfare of our staff. And we think these volunteers can help with that in terms of being able to give people drinks down at our acute units when we're struggling to hand over patients. We think they can help us in some of that area as well. So huge part of our organisation, really vital in supporting us in what we do. And our thanks, as I said earlier on, is extended to these groups of people who do this in their own time alongside very, very busy jobs. So we are really grateful for the support that they bring us. And I think that is me. Yep, it is me. I don't know who's next. Nicola?
I think it's me.
All right.
Thanks,
Thank you.
Ben. Thank you. And I think, Ben, it's probably just worth noting that the development of those community first responders and the introduction of those new roles actually was something that came about after a suggestion from a member of the public at a previous one of our AGMs. So if you do have any other ideas for us, we're always willing to take those, and we do, where possible, act on those. If I could have the next slide, thank you. So I'm just going to spend a few minutes updating you on some of the quality priorities that we have achieved in the last year. And this is based on the quality priorities that we've set out in our quality improvement strategy, which runs from 2020 to 2025, and also in our quality account. I'm just going to go through a few examples in each of the domains, which are clinical effectiveness, patient safety and patient experience. So if I start with clinical effectiveness, Ben talked about the resuscitation strategy that was launched under the leadership of Dr. Leon Roberts, who you'll hear from after me. And in addition to the things that Ben set out within that strategy, that also includes having a cardiac arrest team leader dispatched to those incidents to take control and make sure that we're doing everything to the optimum to get the best outcomes. And I'm really pleased to say that since we launched that strategy, we've seen significant improvement in our ambulance clinical quality indicators that relate to resuscitation. I am going to have to refer to my notes now because my memory isn't as good to remember these off the top of my head. But in terms of return of spontaneous circulation, which is where we manage to get an output back once we've started resuscitating a patient, in the last year we saw a 4% improvement. So ended the year at 44.5% of patients getting a pulse back, which is a significant improvement. And in terms of the patients who then go on to survive to discharge, that has also improved. And whereas previously 1 in 5 patients would have survived to discharge, we've actually improved that to 1 in 4 and are continuing with that month-on-month improvement. One of the other things that we have also seen is in the ACQIs, the Ambulance Clinical Quality Indicators, we monitor things called care bundles, and this is for common conditions that we attend like strokes, heart attacks and sepsis. And this is basically setting out a number of things that we know that if they are done consistently will improve the outcomes for those patients. And what we see from our staff is that despite the challenges that Ben talked about, and we don't always get to patients as quickly as we like, once we do, we are consistently above the national average in terms of performance against those quality indicators. So again, I want to take the opportunity to thank our staff. Under huge pressure, they continue to deliver really good quality of care, and that's obviously in the benefit of our patients. And one of the other things that we've seen is through our learning from deaths and retrospective harm reviews that we've done, we've seen consistently good quality of record keeping and significant achievement of trust and adherence to local policies. So fantastic work from our staff. In terms of patient safety, as Ben outlined, we actually continue to use alternative pathways. So actually of those calls that Ben described, only 50% or less than 50% now of patients actually end up being taken to an emergency department. We continue to utilise alternative pathways, making sure that patients get the right care in the right environment at the right time. And one of the things that we do is we make sure that we monitor things like complaints and incidents to ensure that we are doing that safely and in the patient's best interests, which we definitely do. We have continued to evolve our serious incident process over the last year. You will probably be aware that we have actually reported far more serious incidents in the last year compared to the previous year, ending the year having reported 74 against the previous year of 38, so almost double. And whilst that is not something any of us are glad that we have done, I think what it does show is that gives us an opportunity for learning and improvement, not just for ourselves, but for the system in which we work. And that increase can all be attributed to an increase in delayed response serious incidents, unfortunately. What we have had is very good feedback from both our regulators and our commissioners about the quality of the investigations, our openness and honesty, and the robustness of the action plans that we develop in response to those serious incidents. So whilst it's not good news, there are some positives within there. And then one of the other things that we do is we always, I mentioned learning from deaths before, we always every quarter review up to around about 50 deaths to make sure that quality of care has not been compromised in those cases, and to determine if any of those deaths happened sooner than they might have done as a result of any concerns about care. We reviewed 185 deaths in 21-22. Only one of those achieved a care score of 2, which relates to poor care, and none of the cases were identified as having been happening at the time that it did as a result of failings in care. So that is positive. And then finally, in terms of patient experience, I'd like to thank now our patient voice group who we continue to work with, and despite the challenges of the pandemic, have continued to meet with us virtually and continue to do work which helps us to review the things that we do from a patient perspective. And some of the things that the Patient Voice Group have done in the last year are things like reviewing our complaint handling process, any media statements that we put out to make sure that they are user-friendly and suitable for the audience that they are intended for. So big thank you to them for their continued support of the work that we do. We've also introduced some innovations in the last year. Ben talked quite a bit about the video consultation that we've introduced, and as Ben indicated, that's really helpful for those clinicians in our control room to have eyes on scene and be able to provide really good advice and make sure that the care that we provide is the best that it possibly can be. And then something else that we've done is we've introduced something called Cuddle Pockets. It's a sad reality that unfortunately some of the jobs that we will attend will be the loss of a child. And what the Cuddle Pockets allow us to do is provide a sensitive way of conveying those babies that have been lost at very early stages, which I know is immensely appreciated by those families who are going through that tragedy. And again, that was something that was a suggestion from a member of our staff. So again, staff, please continue to come forward with your suggestions for how we can continue to improve. So the final slide, in addition to those quality initiatives, obviously one of the things we want to do is protect our staff and our patients as well. So what we did in autumn-winter 21 was deliver a joint vaccination campaign. We delivered the flu vaccination ourselves. That was our staff vaccinating our staff. I'm really pleased to say that we were able to offer that to 100% of staff, and over 85% came forward and had their vaccination. That actually makes us the best performing ambulance trust, of which we are incredibly proud. And more than 80% of our workforce had the COVID vaccination. 100% were offered, but over 80% had the vaccination. And again, just time for another thank you, and that's to our system partners, because actually it was impossible for us to deliver the COVID vaccine for all sorts of logistical reasons, and our system partners stepped forward and offered that vaccine to our staff. So that is very much a whistle-stop tour. If you want to hear more about quality initiatives, then please do read our quality account, which is available on our website and NHS Choice's website. And I'm now going to hand over to Dr. Leon Roberts, our Medical Director. Thanks, Leon.
Good morning, everybody. My name's Dr. Leon Roberts, and I'm proud to be the Medical Director here at East Midlands Ambulance Service. We've heard a little bit about the way we respond to patients and develop, and it's my role now to talk a little bit about our collaboration. In January of this year, we were really fortunate to head to Rutland, to Kendrew Barracks, to welcome 60 members of the armed forces who we proactively worked with to join us to respond alongside our staff to some of our patients. Ben mentioned about our tier of urgent care crews who respond to our lower acuity patients, our patients that need transfer into other healthcare settings. These often come from GP calls, these come from other allied healthcare professionals or hospitals that require the transfer of patients. It removes the burden on our emergency crews who want to get out to those other emergency patients as promptly as possible. And we're hugely grateful for, I think, mainly members of the Royal Navy who joined us here in the East Midlands, working alongside our urgent crews, freeing up that capacity for our emergency service. And in a very similar way, our blue light collaborators in every area of the East Midlands, so across Derbyshire, Nottinghamshire, Lincolnshire, Leicestershire, Northamptonshire and Rutland, our fire and rescue colleagues again joined us working shoulder to shoulder with the urgent care crews, providing support and response, assisting with the manual handling and movement of our patients to where they needed to be. Ben spoke about our doctors in our control room who've been working alongside our clinical assessment teams, but that's only a small fraction of the clinical partnerships that we've formed, established and embedded over the last 12 months. And some other small examples have included working with the Nottinghamshire hospices allowing our ambulance crews direct sort of access to end-of-life and palliative care support, and indeed emergency admission for patients nearing the end of their life, allowing a dignified death in the right setting. In addition, we've been working with joint emergency services in the East Midlands, and more recently partnered with the Derbyshire Community Health Services, where we've formed a new health hub in Bakewell, which we're hoping to see completed in the summer of 2023. There is a heartfelt message from me, and that's to all members of the NHS that have worked alongside our crews. We've worked in some really clinically demanding situations over the 2021-22 period, and it never fails to amaze me about the collaboration and engagement we've had with partners, our primary care colleagues in particular, working remotely and with access to the patient's notes, supporting our crews to make the right decisions for patients. I am really indebted. And likewise, our emergency colleagues in the A&Es and emergency departments in the region who are under unbearable pressures, looking after our patients in difficult circumstances. I am truly grateful. Thank you.
Good morning. I'm Mike Naylor, Director of Finance, and I'll start with apologies. There's nowhere on earth I can make my presentation on accountancy anywhere near as interesting as what you've had before, so I do apologise. And and just to go through some of the numbers, it's 258 million annual turnover, so £250 million, a big organisation. We spend a lot, and we make sure we spend it wisely. We achieved all our financial targets, and given everything that's going on, a heck of an achievement, particularly towards the end of the year. And you saw earlier on the presentation from Ben about how the ED delays are impacting upon our services. And that has a financial impact because we've got to backfill all those lost hours. And that cost pressure has really hit us at the end of last year and has rolled over into this year as well. We improved our productivity. We achieved £4.8 million of cost improvements during the year. So we made ourselves more efficient. We invested £11.8 million of capital, and that's the amount we got. The capital expenditure limit is the amount we can spend, and we spent that on improving our accident emergency vehicles, critical care information technology. We talked about the iPads, and we've seen those benefits of the iPads now in terms of the information we can now collect and process, and £1.8 million on estates. We kept ourselves in a very healthy cash position, 25.7 million cash balance, and a slight increase from the previous year. So we kept our finances in order last year, and given we're in the middle of coming to the end of a pandemic, we had all sorts of issues in EDs. I think it's credit to all our budget managers in the organisation. And I always say I don't spend the money, I just make sure it's counted properly. So the people out there have been doing a great job balancing the demands of the service with making certain that we keep financial control. And you'd be glad to know just one more slide, and then you can. So we've got some financial targets to achieve. But first of all, we had an allocation of COVID, £13.7 million additional money we got for COVID last year. We spent the vast majority of that on additional staffing through private ambulance services, and additional overtime and additional call takers, as Ben was outlined earlier in the call centre here. We've got requirement to make certain we pay our creditors on time. A lot of people depend upon the trade they have with the ambulance service. And given everything that's happening in the economy, we try to make certain we pay our suppliers on time, particularly those local suppliers. And you can see there that by number and by value, local suppliers, 98.5% were paid within 38 days. Slightly not below the 100% because often you get little queries with invoices. So we've done our bit in maintaining the local economy as well. And you've got to remember that the NHS is big business for a lot of people. And we do our bit to make certain they get paid on time and keep their cash flow going. So we made a surplus of £1.2 million after adjustments. I won't go through what those adjustments were. They're all very technical, but I'm quite happy if anybody's got 2 hours after this meeting, I'll go through the balance sheet with them with those adjustments. But need to say we achieved our target, slight surplus there. And those people who are interested and find difficult going to sleep, the full report and accounts are available. Just going to do is ask me. Big, thick thing like that. I did read them, actually. They are quite interesting, but I'm an accountant. So that's it from me now, and I think I hand back to Richard. Thank you.
Thank you very much, Mike. So Huge thank you very much to everybody once again. As I started the presentation this morning, was a thank you to all of our staff, our volunteers, our stakeholders, our partners. Without the dedication, determination, the work, the partnership working, we would not have been able to achieve what we have done. We know there have been some very, very tough times, some very challenging days, and we know that those periods of time and challenges will continue. But again, a huge thank you. I'd also like to personally say thank you to my executive team as well, who some of you've heard from this morning, for all of the leadership they've provided across the whole of the organisation, who without them, we would not have been able to deliver what we have done. So a huge thank you. I believe now we're into questions, of which obviously I will open up questions within the room, but I also believe we have some written questions, which I will read out and answer. So the first one we have from John Dick from the Derbyshire cohort of the Patient Voice. John, you're actually with us this morning. Would you like me to read the question out, or would you like to ask it in person?
I can respond as well.
Okay. So the question is, could I ask if delays in getting patients into hospital is caused by the number of beds not allocated for secondary care in community hospitals for hospital patients to be discharged to? For example, St Oswald's Hospital Ashbourne has 25 beds, only 10 are allocated / staffed. Why? ? And other community hospitals may have the same spare beds. Now that there is an integrated care system, Joined Up Care Derbyshire and other phrases used, e.g. better care closer to home, is it not time to implement services for the benefit of the patient? The integrated care system became the statute law as from the 1st of July 2022. Working together has to be seen to be working for the benefit of the patient. Fantastic question, John. Thank you very much. What I'm going to do is invite Will Legg, one of the directors, who's going to give a specific response to that question, please. Will.
Thanks very much. Thanks, Richard. And thanks, John, for the question. I'm going to take it in two parts. So the first part around the community hospital side and the second part around ICSs. So I took the opportunity to talk to Derbyshire Community Health Services yesterday about that specific question. So thank you for sending it in advance. That really helped us. Basically, when you look at that link between handover delays and what's happening in hospital, you're absolutely right. There is a link between what happens in terms of our delays of taking 999 patients into hospital, the delays that happen there, and then what happens the other side of the hospital in terms of discharge. There's usually 3 different ways that patients leave a hospital in terms of going home, going into community hospital, as you quite rightly identify in your question, and also into a care or nursing home bed as their kind of normal permanent residence after that hospital visit. What Derbyshire Community Health Services have assured me when I spoke to them yesterday is, in terms of the number of beds for the community aspect, so the community bed aspect, they've looked really carefully in Derbyshire at how many are needed for the patient acuity that they're seeing. So the numbers of patients coming through which need that kind of, they call it step-down facility, but it's basically when you've been in hospital and you need a bit of rehabilitation before you go home, it's for that particular facility. They've looked at how many beds they need for how many patients come through needing that, and they assure me that's about the right number. Now, actually, you'd say, well, if that's the right number, then why are we still seeing all these delays in hospital? Which is absolutely, you're absolutely right, there are still those delays. And that's to do with social care capacity. So care home bed capacity in Derbyshire in particular is okay. And it's actually the social care packages. So it's the ones where you'd have domiciliary care and care in people's homes. It's that support and arranging that support. It's the capacity around that which is the particular challenge in Derbyshire. So that's the kind of the sticky point at the moment in the system, and that's what ultimately backs all the way up through hospital back into what with the delays that we unfortunately see, which Ben talked about as part of his part of the presentation. In terms of the ICS, you're absolutely right. So the ICSs give us a fantastic opportunity to really integrate the ambulance service and the work that we do into the community even further than we do already. So there's already conversations happening, which I'm sure you're aware of, John, in Derby and Derbyshire, looking at the role of ambulance services, specifically aligned to primary care and a lot of the capacity challenges in primary care, and where there's things that we can do in the ambulance service to align our services to the delivery in primary care to try and support in a much greater way than we do at the moment. Those conversations are live, they're underway. We're looking at trying to do some pilot work around some of those things in the near future. So watch this space and you'll see some innovation exactly in that area. But rest assured, we're absolutely part of the ICS in Derbyshire and also part of the ICSs across the whole of the East Midlands, as you would expect us to be. Thanks very much for your questions, John. I hope that answers them.
Yeah, I only wanted to say that it all seems to be the ambulance's fault that there's so many delays, and yet there are available beds in community hospitals where people could be transferred for secondary care for 3 or 4 days, and maybe they're waiting for a care package to be established for them to be discharged. I just think there is that opportunity where you've got 25 beds and only 10 are being used in a community hospital. Why not have that 15-bed space made available? And whether it is because the previous clinical commissioners only commissioned for a number of beds to be used in that community, and therefore only fund that number of beds, that maybe that's the knock-on effect now that we should be looking at, how we work collaboratively so the patient actually is discharged into a secondary care unit, albeit for a few days, and that relieves that bed in the hospital to discharge the patient from the ambulance. That's my way of thinking. Whether it's that now practical situation, and it's now the closer working together in the integrated care system that will enable the patient to have a better outcome.
Yeah, I completely agree, John, and you're absolutely right. The ICS brings all of the organisations into almost one organisation overall in the ICS to be able to tackle those kind of wicked issues.
From a patient's perspective.
Absolutely agree.
Thanks, Will.
Thank you.
Thank you, Roy. Thank you, John. So the next question I have is from a member of the public, Martin Chapman. I am not a member of a CFR scheme, but do follow their progress on Facebook and value their work. I can see they regularly cruise shifts, effectively acting as a resource. This only enhances the 8-minute response times and promotes best care. In London, the London Ambulance Service have successfully deployed fully level 3 trained CFRs on cars equipped with blue lights and sirens. Those who drive are level 3 CFRs who have also undertaken a recognised blue light driving course and only qualify to drive these vehicles. Will EMAS consider a feasibility study into whether this is appropriate for the EMAS ethos? So thank you, Martin. Great question. During the presentation this morning, Ben obviously described some of our exciting vision and strategy around community first responders and what we are hoping to achieve and work with them. We know the contribution that they give to the ambulance service is significant and have a huge, profound impact. Day in, day out, they contribute to and indeed save people's lives through that early intervention. What we need to do is get that balance right around, first of all, getting the strategy in place, making sure we have the right amounts of schemes in place across the organisation, and then we'll consider further any additional developments which we have to kind of bring to the forefront. We do have a number of people who will respond on blue lights, so many of those will be trained ambulance personnel and or doctors who respond on behalf of the ambulance service, but also in Lincolnshire, for example, we have the Lives CFRs, who a number of those colleagues also will respond under blue light conditions. So again, it's something which we'll continue to review, but at this stage we don't have any additional plans to train further CFR schemes in the use of blue lights, but we will obviously engage with our CFRs as and when we need to change.
Just adding to that one, very brief, but we do have plans around level 3. So it's the question split into two about level 3 and blue lights, which is absolutely right about the strategy doesn't include the blue light bit, but it does the level 3. And we're keen to develop that area. We don't know whether there is a benefit of the blue lights, but as Richard said, we'll evaluate that as we go forward.
Thanks, Ben. And that gives an opportunity for any questions at all, please, from anybody who's with us here in the room this morning.
Can I just comment on
Please, you.
Yeah. I also share the 50+ Ashbourne, and we've had a new pavilion built. Oh, thank you. We've had a new pavilion built in Ashbourne. I was asked what can we use the lounge for, and we're using it for a computer hub, and we're calling it the T-Talk Tech Cafe. But we've involved the voluntary sectors, the platform housing, Rural Action Derbyshire, Derbyshire Dales Council Voluntary Services, and Connex. We have not paid one penny piece for the service. They are providing the staff, the computers, the tea and refreshments, the cost of the room, and so on. And it's working together to provide that community voluntary organisation project and input into the community. We're also including the sixth form centre students to come in, because it's during the day, 11 till 1. It's actually today, 11 o'clock to 1 on every Thursday, and people are coming to learn how to use a computer, and it's for the benefit of their health and well-being, because they then need to understand how they access the services that they can be provided with. But the other thing, the talking factor, they're talking to the voluntary organisers who are professionally trained, qualified and so on, in giving them advice and information on where services are available to them for their health and well-being. And this has now set up another idea and project to have a staffed information hub in every hospital to give advice and information to people verbally, not just leaflets, because leaflets can be just thrown away. And I think that's the next project, of working those voluntary organisations together to provide that service. And here you are in the ambulance service, falls prevention, a classic example. My wife got a new button yesterday because she'd had 3 falls, but there's a necessity for anybody to understand what is available to them. And certainly from a doctor's perspective, my doctor said, thank God somebody's listening, because it would take the effort and stress away from me for people coming with, we'll say, minor concerns that could be easily recognised and given them support to know how to use the services that are provided in their own community.
Thank you, John. And again, a great example of the really the huge invaluable role that volunteers play and how communities can come together to support the greater good. So thank you so much. Any other questions, please, from anybody?
Hi, I'm Georgia. I'm from the BBC. I actually have a question for yourself, Ben, and also for Mike as well. When you were talking about, it's obviously, can I take the box? One second. So that figure, when we were talking about hospital delays earlier, increase of 110%, is that right, on last year? Obviously, that's a big increase. You were talking about improvements that you're working on to try and combat that. Can you just go into that a bit more about what you're working on? Because obviously going into this winter, we hear all the time about the NHS already running on high, especially when it comes to those lost hours, delays that already are a massive concern. So can you just go into a bit more about those improvements? And also, again, on the lost hours, Mike, you were talking about cost pressures that's brought to the service. Can you just go into a bit more what those pressures are and how they might be impacting finances? Thank you.
Okay, thank you. So I think I'll answer that question in 2 ways. I think there's, as I said in my presentation, we EMAS won't fix this on our own. We can't fix it. We need support of the systems to fix it. So it's a system approach to this. And I think there's 2 ways that we're looking at this. Is how can we reduce the burden on the A&Es? Because as Mike and Leon alluded to, they're under huge pressure as well. So how can we reduce that by only taking in the patients that really need to be there? And the ones that really need to be in the ED as well. So all the other areas in the hospital we can take patients directly to. So same day emergency care, for example. Can we take patients directly to there rather than the front door of the hospital or the ED department? So, but we must, I think from an ambulance point of view, we must accept there are always patients that need to go to hospital. You know, we cannot deal with all of them in a different way. And I think there is some belief that we can. So we need to be honest saying that there will always be patients that need to go to hospital. It's just we need to make sure that we're only taking the ones that really need to be there. And we've done amazing work on that over the last couple of years. And I can't remember if Nicola or Leon mentioned, we now take less than 50% of our patients to the front door of an ED. So I'm not sure there's a huge amount to go out there now. I think that's the majority of it's done, but we will continue to work with systems on that. And the second part, which I think is probably more important than the first, is around the flow. So the flow of patients once they're in hospital and then out, as we were talking about there, into the community. We hear about patients that are stranded in hospital, length of stays going up, etc., etc. So our work with the systems is really to how can we support them in getting the message around risk, around sharing the risk of moving patients on so we can lessen the risk at our end of patients waiting in the community. Again, we're not blaming, we're not pointing fingers at certain parts of the system. It's about all of us recognising the importance of what part we all play in. And we talked about the beds in the community. We're really keen to see that they're properly utilised, because it will help us attend to patients quicker. And we've got far more involved in that than we ever have been before. So I think they're the two elements of that that we're working on with the system.
Can I ask, sorry, just to follow
Good.
up, because I predominantly cover Derbyshire, and when we were talking with John, there was mention of a particular problem in Derbyshire when it comes to the flow that you're talking about. Are you particularly concerned about Derbyshire in this aspect, opposed to the other areas?
No, not well. Equally, I think concerned. We used to have handover problems at 1 or 2 acutes across our region, predominantly Leicestershire and Lincolnshire. We're now seeing it across the board now, so we have problems everywhere. And when we talk to those systems and when we talk to those acutes, it's the same challenge that they face, which is around the system coming together to answer that flow issue. So I'm not more concerned about one area than the other. I think they're all up there now on our worry list, and we're working with all of the systems through our divisional teams to try and improve that.
Thanks, Ben. Mike, do you want to answer the finance part, please?
I will do. I'll just stand here so we can get recorded, so not I'm actually more comfortable standing than sitting. Yeah, the ED delays provide risk, and we identify clinical risk, but the financial risk as well. And that manifests itself in probably 2 ways. One is that the immediate impact on our staff. So when people work longer shifts, we pay them overtime. They miss the meal breaks, we've got to give the meal break payments. But also then we've got to fill those lost hours. And we fill those lost hours in 2 ways. One, by putting additional overtime out, which has got a cost to it. And the second is by getting more ambulances in. And we tend to go to private sector for those. There is a cadre of private sector providers who are available and allow us to backfill there. Now, so at the moment, that risk is being carried by EMAS, so we're carrying that on our books. But one of the things that the new NHS reforms has done is actually allow this system working. So we're sat down, myself and Richard, with all the systems now, with our capital officers, look at identifying what that financial risk is and how that can be recompensed to us. So in sum to your question, it's the costs are about backfilling the hours and also the cost of additional hours, but we are talking about how we're recompensed for those. So I don't know if that answers your question.
Yeah, I was just wondering, so are you also still working out whether you can come up with an actual figure as to how much it's actually costing?
Yes, and we actually, what we've agreed is with the systems is that when we get to a stage where we can agree the figure, we'll have an open book approach. We don't want to make any money out of it. So yes, so we know, for instance, in terms of we made a decision as an organisation to maintain our whole time equivalents at last year's levels. So we've got a figure for that. We know how much money, what the actual cost of missed meal breaks payments are. We know the actual cost of overtime that staff who are working and doing, and we know the cost of additional overtime. Then there's a bit about the additional private ambulances, some of that related to ED delays, some of that related to covering for COVID, for instance. We've still got COVID kicking around, so some of those bit more subjective. Some are very definite, yeah, we can put pound and pence on it. Some say, well, that's going to be about 10, 15%, 20%, and that's a bit more in agreement with our commissions. But what we have said, that as an organisation working together, we don't want to make a profit out of this, just to recognise what the cost is to EMAS, so we can invest that money back and maintain the level of services. Thank you.
Thank you, Mike. Thank you once again for the question. Any other questions, please, at all this morning?
Can I just comment on another experience?
Yes, please do.
Thank you. It's interesting. This is for the future, I think. I sat as a patient representative on the East Midlands Clinical Senate, looking at the proposals for the Queen's Medical Centre and the City Hospital. And it came up with transfer of patients from one hospital site to another. And it was using ambulance services. And I thought the first thing would be traffic jams, congestion. And I looked at how how the city were developing the tram system. And there's already a tram stop at Queen's Medical Centre where they use I think it's the Towton sidings or the Towton park and ride. And 2 streets away is from the tram line is City. And I thought there's an opportunity for working together to provide a trambulance to transfer patients from City to Queen's Medical and vice versa. And working in conjunction with the City, who are still developing the tram system, and the future for the tram or the electricity factor, because you've already got electric ambulances operating in Northamptonshire. And I just thought that's something for the future to consider, and what an easy ride it would be in a trambulance rather than Humpty Bumped over all sorts of congestion for a patient from one site to another.
Thank you, John. Another valuable contribution. So on the end of that, I'm going to say thank you very much for everyone's time this morning. Thank you for your interest in East Midlands Ambulance Service and giving us an opportunity to talk about our previous year, but also a brief insight into some of the challenges we continue to face and our plans for the future. So thank you once again.